Hello and welcome. I'm Dr. Kelley, and on behalf of CME Outfitters, I'd like to welcome you and thank you for joining us today for today's CMEO briefcase entitled Maintaining the Course, Practical Strategies for Achieving PrEP Goals and Navigating Comorbidities. Today's program is supported by an educational grant from Gilead Sciences. I'm an associate professor of medicine in the Division of Infectious Diseases and co-director for the Center for AIDS Research, or CFAR, at Emory University School of Medicine in Atlanta, Georgia. Our learning objective for today is to understand how to individualize the initiation of PrEP in patients with comorbid conditions. So let's meet Isaiah, a 24-year-old man who presents to his PCP concerned that he has a sexually transmitted infection. Hi, Isaiah. It's very nice to meet you. I understand you have some concerns that you may have a sexually transmitted infection, or STI, we sometimes say.
Yeah, unfortunately, I think I do.
Okay, well, let's talk a little bit more about your sexual history. I'd like to hear a little bit about your partners, who they are, and how you guys have sex, and if you ever use any alcohol or drugs when you're having sex.
Well, over the past couple weeks, we have been sexually active with multiple partners, and admittedly only with sporadic condom use.
Okay.
I'm not aware of any drug use in I am aware of in some of my partners, but not all. And since I know you're going to ask, I too have used drugs.
That's okay. Well, we'll talk more about that. I'm glad that you shared that with me. It's really important that we have as open a conversation as we can about these things, even though it might be a little bit uncomfortable. Have you ever had a sexually transmitted infection before?
No, I have not. It really burns when I go to the bathroom, and there seems to be some sort of discharge from my penis.
Yeah.
I Googled my symptoms and just want to get them checked out and be treated if necessary.
Absolutely. We will take care of that, definitely. So can you tell me a little bit more about the drug use you were talking about?
I don't inject anything. It's mostly like recreational stuff at parties, like relating to sex, like ecstasy, sometimes meth.
Yeah. Okay. Well, that's something I hear a lot about. And, we can talk again more about those things in the future. But I do think we need to, do some STI testing. And we'll make sure that we test at any site where you may have been exposed. So if you're having oral sex or anal sex, we'll need to test orally, rectally, and your urine. It'll take a couple days to get those results back. So I'll have the front desk go ahead and make an appointment for you to come back and talk about your results. In the meantime, though, we should go ahead and treat you today based on the symptoms that you are experiencing.
Okay.
So let's take a minute and review the 5 P's of taking a sexual history. First, you want to understand partners. You want to understand who your patient is having sexual intercourse with, what kinds of behaviors their partners might also be engaging in that could be putting your patient at risk. Next, you need to understand exactly what sexual practices your patient is engaging in. And this includes whether they're having oral sex, anal sex, vaginal sex, etc. So you can understand what anatomical sites are important for specimen collection for STIs. You also need to understand what practices patients are already using to prevent acquisition of STIs. And so that will tell you what level of risk reduction counseling you'll need to engage in. Finally, if someone has a prior history of past STIs, that's important to know their risk now, as well as whether they intend to become pregnant or to father a child in the future. And those questions certainly need to be sex and gender specific. It's important to remember that there has been increased prevalence of methamphetamine use among men who have sex with men. So drug use that is used for sexual activity is sometimes termed chemsex in the literature, and it is an issue of growing concern. Recreational drugs are sometimes used to intensify or enhance or prolong sexual experiences and can include using crystal methamphetamine, GHB or GBL, mephedrone, and ketamine. Drug use in sexual settings is important to know about because it is associated with increased acquisition and transmission of sexually transmitted infections as well as HIV. So let's talk about next steps related to STI testing. What STI testing is recommended by the CDC? Here on this slide, we have an overview of the CDC STI testing recommendations. So don't forget, all adolescents and adults aged 13 to 64 should be tested for HIV at least once in their lifetime. So that's everyone, regardless of reported risk behavior. For sexually active women, it's recommended that younger women less than age 25 should be tested for gonorrhea and chlamydia every year, and that women over age 25 should be tested for gonorrhea and chlamydia in early pregnancy and then as needed to protect the health of the mother and the child. All sexually active gay, bisexual, and other men who have sex with men should be tested at least yearly for syphilis, chlamydia, and gonorrhea. Those who report multiple partners or other risk behaviors for acquisition of STIs or HIV should be tested more frequently, maybe even as frequently as every 3 to 6 months. HIV should follow a similar testing frequency, and then don't forget to test for hepatitis C at least once a year if in MSM who are HIV positive. Anyone who reports sex without condoms or sharing injection drug equipment should be tested for HIV at least once a year. And people who engage in oral and anal sex should talk to their healthcare provider about risk of acquisition of STIs at these non-traditional sites as well. So let's go back to our clinical encounter with Isaiah to discuss his lab results. Hello, Isaiah. As we were expecting, your gonorrhea test did come back positive. Both your chlamydia test was negative. However, your syphilis test also turned up positive. We have already treated you for the gonorrhea, but now we need to address the syphilis. I'd also like you to know that your HIV test was negative, so that is good news.
Okay. Well, honestly, I was kind of expecting the gonorrhea. Can it be treated?
Yeah, so now we need to, as I said, treat the syphilis. So I do need to have you come back into the office and we will give you a shot of penicillin. It'll just be a one-day treatment shot of penicillin and it will cure it. So that's good news.
Okay. Just one shot is needed.
Yeah, that's absolutely right. So we've treated the gonorrhea and now we'll treat the syphilis and you'll be taken care of today. But before you come back over, I did want to talk to you about your HIV test. You were HIV negative, and that's great. And we want to make sure that you stay HIV negative and healthy. Condoms can protect you from STIs as well as HIV, but it's really hard for people to use condoms perfectly 100% of the time, like you told me before. So I'd like you to consider using PrEP. Are you familiar with the daily pill prevention for HIV prevention?
I have heard of it, but I never thought I was much at risk. And in the past, I have been good about using condoms, but I get a little carried away at these parties sometimes.
Well, that's exactly a good reason to use PrEP. You do the best you can with condoms, but because sometimes you don't use condoms, PrEP is there to protect you from HIV. So I recommend that you consider it. It's really hard to be 100% perfect using condoms all the time. So this is an excellent way to have a backup on board all the time to keep you HIV negative and healthy.
Okay, I guess it all sounds pretty straightforward. Are there other things that I need to think about before making a decision?
So what HIV prevention strategy would you recommend for Isaiah? Now let's take a minute to review the results of the Discover trial that compared daily oral FTAF, which is emtricitabine and tenofovir alafenamide, to FTDF, or emtricitabine plus tenofovir disoproxil fumarate, for HIV prevention. On this slide, we can see that both agents taken every day to prevent HIV infection were extremely effective. At both week 48 and week 96, there were very few HIV infections in either trial arm. And the trial did meet its pre-specified endpoint of non-inferiority comparing FTAF to FTDF. The trial also showed some small differences in serum creatinine and bone mineral density that favored FTEF over FTDF. Now, it's important to note that these are biomarkers of kidney function as well as bone mineral density, and we do not know how important these outcomes are for actual clinical kidney failure outcomes or fractures, but it is something that's notable. So in general, these medications are equivalent, and you could consider using FTEF in someone who has pre-existing renal disease or who is at high risk of osteoporosis or renal disease. Event-driven PrEP is another option as opposed to daily PrEP that allows patients to choose which PrEP regimen works best for them. So event-driven PrEP is endorsed by the WHO and includes taking 2 pills of FTDF 2 to 24 hours before sex, another pill 24 hours after sex, and a 4th pill 48 hours after sex. It has been shown to be equally effective at preventing HIV infection when used in this way. And so a study has shown that of 367 participants, 73% chose daily PrEP, and over a quarter chose event-driven PrEP, showing that people prefer some regimens over the others, and that switching between these PrEP regimens is extremely common and can be associated with sexual-related determinants, including use of chemsex, sexual compulsivity, sexual behavior with known HIV-positive partners. And that discontinuation rates between both regimens was low when people were allowed to choose which regimen worked better for them. It's also exciting to think about long-acting injectable PrEP that is in development. Long-acting injectable cabotegravir may offer a safe and effective alternative for HIV prevention and was shown to be superior to FTDF in the recent HPTN 083 clinical trial. It is an integrase strand transfer inhibitor that's given intramuscularly every 8 weeks. This trial was conducted in MSM and transgender women in the US and other countries, but also among cisgender women in sub-Saharan Africa. 81% of cabotegravir recipients did report injection site reactions, and these were mostly mild. And it's important to note that in participants in whom HIV infection was reported, INSTI resistance and delays in detection of HIV were noted, but overall HIV acquisition was extremely rare in the clinical trial. So Isaiah, I'm really glad that you're choosing PrEP. I think it's an excellent decision. We're going to be doing some routine follow-up to make sure all is going well, to make sure you're tolerating the medicine and continue to be HIV negative while you're taking the medicine. Let's talk about something called adherence. That means taking the medication every single day as best you can. There are medications that you miss a dose or two is fine, but with PrEP, you really do need to be diligent. Now, you shouldn't worry too much if you miss a dose or two, but overall, you need to make sure that you're taking your PrEP as many days out of the week as you possibly can.
Okay. What can happen if I don't take it?
Yeah, because the 2 drugs in PrEP are the same drugs or ingredients in some HIV medications. If you were to take your PrEP not very well and then to become HIV positive while you were taking it, it's possible you could develop resistance to the medication, which will make it harder to treat your HIV in the future. That said, I wouldn't worry too much about this because, we really just need to make sure you're doing the best you can taking your PrEP every day.
Yeah. Okay. Yeah, I'll try to be good about taking the medicine.
Okay. I also want to revisit what you told me about your drug use and also talk about your mood a little bit.
My mood, like depression, is that what that one form that we did was for?
Yes, that's absolutely right. That form is called a PHQ-9, and it's a score that we use to calculate people's symptoms of depression. And because of that score, which was 10, and when you shared with me about your substance use, I think it would be important for you to talk to one of my colleagues.
What does the 10 mean?
A PHQ-9 was administered to Isaiah during the visit, and his score was 10. What does that score indicate for Isaiah? So mental health, depression, and anxiety in particular are very important barriers to perceived, or very important barriers to PrEP adherence. And so it's important that we understand whether these factors are operating in our patients. And in this case, we use the PHQ-9 tool to determine depression severity in our clinical case. And this is a very simple and useful tool where we can grade depression severity and then pursue proposed treatment actions that you can see summarized in this slide. A PHQ-9 score of 10 correlates with moderate depression, and the treatment plan should be considering counseling, follow-up, and or pharmacotherapy. And you can read the other treatment recommendations here on the slide. Mental health and substance use disorders often go together and are particularly important to assess in men who have sex with men at risk for HIV and STIs. Gay and bisexual MSM have poor mental health outcomes and are more likely to use recreational drugs compared to other populations. And these inflictions can interact with one another in something called syndemic theory, where two things, social, biological, or mental health factors, can reinforce each other and become synergistic and contribute to an excess burden of disease. So it's important to assess for both of these factors. An integrated approach to mental health and addiction services at PrEP initiation and follow-up should be considered for all patients. On this slide, we review the very critical role behavioral health providers can provide in both the prevention and treatment of HIV. On the left here, we have folks who test negative for HIV. On the right, a confirmed HIV diagnosis column. And here we can see both in clinical reporting, coordination of care, linkage to HIV prevention and treatment services, as well as follow-up and monitoring, can all be supported by behavioral health providers and good case management to help patients mitigate those factors that are preventing them from achieving good HIV prevention care or treatment wherever they may fall on the continuum. So just to review again, substance use and PrEP adherence, this relationship is very complex, and we need to really consider what substances are being used and the context of their use. Are they being used before or after sex? Are they being used every day, et cetera? Among 226 HIV negative Black MSM, substance use behaviors were not significantly associated with PrEP initiation and adherence. So this is a good reminder that reporting substance use should not prevent you from offering PrEP or HIV treatment services to patients. However, stimulant use before and during condomless anal intercourse was significantly associated with lower odds of PrEP adherence. And so these folks might need additional support for adherence to PrEP. So on this slide, we'll review what kind of longitudinal follow-up is necessary for people using pre-exposure prophylaxis. So 3 months after PrEP initiation, it's important to test for HIV, and every 3 months after that. It's recommended to check serum creatinine and estimate the creatinine clearance, as well as to provide adherence and behavioral risk reduction support. For MSM, it's recommended to screen for bacterial STIs every 3 months after initiation of PrEP. And for women of reproductive potential, it's important to test for pregnancy. For people who inject drugs, you need to assess access to clean needles and syringes, as well as provide referrals to drug treatment services. As I said, every 3 months after initiation of PrEP, it's important to test for HIV, as well as to support adherence and give behavioral risk reduction support. Bacterial STI should be screened for every 3 months among MSM, as well as pregnancy testing among people of reproductive potential and people who inject drugs, again, to assess access to clean needles and syringes. Finally, it's important every 6 months that we're measuring serum creatinine and estimating creatinine clearance, and then for all sexually active participants, not just MSM, to screen for bacterial STIs at those 6-month follow-up visits. So there are some very real barriers to PrEP adherence, as well as perceived barriers to PrEP adherence that are important to note. Substance use has been found in sub-studies, as well as side effects, poor health status, perceived low risk of HIV infection, inconvenience, social stigma, as well as the very critical social determinants of health, including poverty, racism, and access to healthcare, all can become barriers to PrEP adherence. And so it's very important to recognize these in our patients and attempt to mitigate them as best we can. There are many factors that can facilitate adherence to PrEP at the individual, provider, and societal level. So at the individual level, some things that can help support adherence include external reminders like on alarms or automated phone reminders, using pill boxes, tying PrEP taking of the daily pill to another daily activity such as brushing your teeth, understanding the real risk of HIV infection and that it does not require very high risk behaviors like multiple partners or drug use to be exposed to HIV among certain populations. And also to stress the perceived benefits of PrEP and really being a healthy choice to remain HIV negative. There are provider factors such as establishing good rapport, communication, and consistent quality of care, as well as giving counseling sessions tailored to individual needs, which are unique and for every patient, as well as ongoing counseling during follow-ups. And let's not forget that societal support, including family and peer support, are incredibly important in PrEP adherence, including payer assistance, which can help mitigate some of the costs associated with PrEP. So let's summarize our discussion with SMART goals that are specific, measurable, attainable, relevant, and timely. That is what I hope you will take from this presentation to apply to your practice. An evaluation for PrEP should include a non-judgmental sexual history to guide the assessment of risk for HIV infections and STIs. You should certainly inquire about comorbidities such as substance use and mood disorders that may increase sexual activity and risk-taking. And you should counsel patients who are initiating PrEP about the importance of treatment adherence. You should educate them about strategies, tools, and tips to support adherence and mitigate any barriers to achieving effective HIV prevention with PrEP. So today's CMEO BriefCase is part of a 3-part series of case-based activities that can be found on the Infectious Disease Hub at CMEOutfitters.com. I hope you'll check out the other 2 activities in the series. The Infectious Disease Hub has these activities and many other activities on HIV. CME Outfitters also has an HIV patient education hub with a number of excellent resources, videos, and whiteboard animations to share with your patients. Finally, thank you for joining me today. Don't forget to complete the post-test and evaluation. And as a reminder, this activity is also available for ABIM MOC credit. Stay safe, and thank you again for providing the best care you can for your patients.